will you be able to help us record, sir? We're starting just...
No problem.
Started the recording. Thank you.
You can start, sir. Thank you. Dr. Somalia, sir, you can start. I don't seem to hear you. All right. Thank you, sir.
All right. Good evening, everybody. Good evening. I'm Modu Sumaila from University of Blood Teaching Hospital. I will be presenting fetal circulation and the extrauterine transition. That is the transition into neonatal circulation. Please, if I'm not audible, let me know because I sometimes both Glow and network, both Glow and MTN that I'm using, I don't know if they are doing well right now this evening.
Oh, no, sir. So continue,
I'll
sir.
be starting with an introduction. Slidation. Fetal circulation refers to the circulatory system of human fetus, and it occurs during intrauterine life, and it comprises the entire fetal placenta blood flow, including the umbilical cord and the blood vessels within the placenta that carry fetal blood. It is actually a complex circulation that makes one wonder, how does this happen naturally? So, before birth, the fetus obtain oxygen and nutrients from the mother through the placenta and the umbilical cord. The blood from the fetal heart that is destined for the lung is shunted away from the lungs via a short vessel called the ductus arteriosus and returned to the aorta. And the persistence of this beyond the usual period it leads to what we call the patent ductus arteriosus. So the component of the fetal circulation include a placenta. So what is this placenta all about? As far as placenta is concerned in this presentation, it is the organ that connects the developing fetus to the uterine wall. It enables nutrient uptake, provide thermoregulation to the fetus, eliminate waste products, gas exchange via the mother's blood supply, and it fights internal infection and produce hormones to support pregnancy. So this is a diagrammatic representation of a cross section of the placenta. I don't know if my cursor is visible. So when I'm pointing, I will know that. Is it visible?
Yes.
Is my cursor is okay? I don't think it is. Wow. Okay. So is it visible now, sir?
Yes, we can see the point.
There's a delay in the.
We can see it. Yeah.
So this is the cross section of the placenta. So this is the cross section of the placenta, showing the fetal maternal relationship. So this is the umbilical cord containing the umbilical vessels I guess my cursor is visible, right?
We can see it, sir. Thank you, sir.
Eliza.
We
All
can.
right. So this is the. Oh, all right. Thank you. Umbilical cord containing the umbilical vessel going into the placenta. And this is the maternal side. The red one on the fetal side is the umbilical vein that will take away the blood from the placenta, and the blue one is the umbilical artery that will bring blood to the placenta from the fetal side. Then on the maternal side, the usual color of the arteries and vein that we know remains the same. The red for the umbilical for the uterine artery from the mother that brings the blood to the placenta, and then the vein, the uterine vein that takes away the waste products and the waste from the fetus. So the blood diffuses into this part of the placenta, and then this is the place that the diffusion takes place. Both the maternal and the fetal blood, there is no direct connection between them, but through the diffusion, the fetal, the umbilical vein takes up the oxygen and the nutrients from the maternal from the placenta, which is supplied by the maternal artery, uterine artery. So sorry, I'm to move my slide. Hey, wow. This slide, thank you. So the this is another view of the same diagram. So I'll not waste time on this. So the role of the placenta, the core concept of the fetal circulation is that fetal hemoglobin has a higher affinity for oxygen than does adult hemoglobin. So it allows the diffusion of oxygen from the mother's circulatory system to the fetus. And when they come into close contact like that in the placenta, the diffusion occur freely from the maternal side to the fetal side. And because the fetal hemoglobin has more affinity, a better affinity than the adult hemoglobin, it acquires more oxygen. It acquires oxygen preferentially from the maternal side. That is the placenta. The circulatory system of the mother is not directly connected to that of the fetus. So the placenta functions as the respiratory center for the fetus, as well as a site of filtration for plasma nutrients and waste. The placenta almost function like everything for the fetus. Water, glucose, amino acid, vitamins, and inorganic salt freely diffuse across the placenta along with oxygen. The umbilical arteries carry blood to the placenta, and the blood permeates the sponge-like material there in the placenta, and like the way it does in the lung. Oxygen then diffuses from the placenta to the chorionic villus and alveolus, alveolus-like structure, where it is then carried to the umbilical vein. Blood from the placenta is carried to the fetus by the umbilical vein. So less than a third of this blood enters the fetus ductus venosus. The ductus venosus is like a shunt that connects the umbilical vein to the IVC, and is like a device to prevent all the oxygenated blood from going to the liver, so that the other part of the body that are very essential will get well oxygenated blood. So the rest of the blood goes into the liver. The branch of the branch of the umbilical vein that supply the right lobe of the liver first join the portal vein. So everything that enters the IVC then goes to the right atrium. From the right atrium to the through the foramen ovale, preferentially, it moves through the foramen ovale. The oxygenated blood, most of the oxygenated blood moves through the foramen ovale to the left atrium and then to the left ventricle. From there, when the blood is pumped by the left ventricle, it moves to the the blood that goes through the blood that comes from the right atrium, the blood that goes into the right atrium is not all of them that goes into the through the foramen ovale to the left ventricle. Some of them goes into the some goes into the right ventricle, and those ones are pumped into the pulmonary artery. This blood is destined for pulmonary for the lungs. However, because the lung is not participating in the is not actively doing performing the function of respiration at this stage, because the fetus is suspended in the water, and the lung is not respiration at this stage. The blood will be is diverted through the ductus arteriosus into the aorta. So this blood that comes from the right ventricle, they are less oxygenated. Usually, most of this blood goes into the lower part of the body, and then from the abdominal aorta to the internal iliac artery. So from the internal iliac artery, the blood moves to the placenta through the umbilical arteries. So this is showing the shunts that are present in the fetal life. The ductus venosus, this is the one that connects the umbilical vein to the IVC. It makes the placenta blood that goes through the umbilical vein. It shunts some of them from the ductus arteriosus. The one I just mentioned, connects the pulmonary artery to the aorta, and it shunts the blood that is destined to the lung into the aorta for continuation of the circulation, since the lung is not participating in the respiration at this stage. Then the foramen ovale is the anatomic opening between the atria, and the blood passes from the right atrium to the left atrium through this foramen ovale in the uterine life. Then there's hypogastric arteries. These hypogastric arteries, because they go into the placenta, and then through the umbilical cord, they are known as the umbilical arteries. So this diagram will explain most of the things that I'm just like a summary of all the grammar that we have been blowing. So if you look at it, let's start from the heart itself. If the left ventricle pumps blood, that is the blood that comes through the foramen ovale to the left ventricle, is pumped. Maybe the best place to start is from the placenta. So from the placenta, the oxygenated blood moves to the through the umbilical vein. We have one umbilical vein and two umbilical arteries. So it moves through the umbilical vein. It gets to this place it goes to this place around the liver, and then most of the blood enter the liver. About a third of it moves through the doctor's venosus to the IVC. So this blood preferentially move into the right atrium and to the foramen, through the foramen ovale to the left atrium. This is a well-oxygenated blood. Among the blood that circulate in fetal body, the most oxygenated is the one in the umbilical vein. So that particular moves through the foramen ovale to the left atrium and then to the left ventricle, and then it's through the aorta to the this one that is pumped through the aorta is the most oxygenated blood, and this one is preferentially goes into the upper part of the body, that is the head and neck, and the then they most of them goes into the upper part of the body. Then they are among the bloods that enter the right atrium. It's not all of them that goes into the foramen, through the foramen ovale. Normal pathway that is going through the right ventricle, and from the right ventricle it will be pumped through the pulmonary artery. But instead of it to go into the lung, most of this blood goes through this ductus arteriosus into the aorta again. So most of this blood that is pumped, that is supposed to go to the lung, is now going through the aorta, and that is the blood that circulates at the lower part of the body predominantly. So this one supply the down part of the body, and the same blood, because it's fully oxygenated, and the one that come from the placenta, this same blood moves through the internal iliac artery, and then the internal iliac artery to hypogastric artery. This hypogastric artery, because it goes into the umbilical cord, it is referred to the umbilical artery at this point. Then also the blood that comes from the head, from the superior vena cava, they enter into the right atrium. In fact, most of the blood that goes into the right ventricle most of them are from the superior vena cava. But other blood from the lower part of the body too also goes through that part. But most of the blood from the placenta goes through the foramen ovale, and that's is it. That is that about the circulation in this at this stage. So please, you can call my attention if you don't get the after the presentation. So this pathway is just the pathway I just explained. So I don't know if there's a need to still repeat them, but maybe briefly. Oxygenated blood from the placenta through the umbilical vein that is going to the fetus, then passing through the lung, is shunted through the ductus venosus to the inferior vena cava, going into the right atrium. Then this blood again is shunted through the foramen ovale to the left atrium, and then to the left ventricle. From the left ventricle to the aorta, when there's during the ventricular systole, from the left ventricle, the blood is pumped into the aorta. Most of them to the through the ascending aorta, most of them distributed to the head, heart, neck, and brain, the brain and the arms. That is the upper part of the body. Then the one that goes through the right ventricle is less oxygenated and is pumped through the pulmonary artery, then through the ductus arteriosus to the descending aorta, then hypogastric artery, umbilical artery, and then to the plasma. This is and then for the exchange of nutrient and oxygen before it goes back again through the umbilical vein. So some other point: the fetal heart and not the maternal heart build up the fetal blood pressure to drive it blood through the fetal circulation. So what it means is that the fetal heart is pumping of the fetal heart is what is responsible for the fetal blood pressure, not the maternal heart. In fact, there's no connection between the maternal, there's no direct connection between the maternal circulation and the fetal circulation. It's just diffusion that occur. So intracardiac pressure remains identical between the right and left ventricle of the human fetus. The BP in fetal aorta is approximately 30 millimeter of mercury at 20 week GA, which increases to 45 millimeter of mercury at approximately 45 millimeter at 40 weeks GA. The fetal pulse pressure is about 20 millimeter of mercury at 20 week GA, increasing to 30 millimeter of mercury at 40 weeks gestational age. So the BP decreases when as it passes through the placenta. In the umbilical artery is about 50 millimeter of mercury. Then at the capillary in the placenta is about 30 millimeter of mercury. And then going back into the umbilical vein is about 20 millimeter of mercury. So the circulatory changes that occur at birth. So the changes that occur at birth are not due to the tying of the umbilical cord, but rather to the establishment of the respiration. For the physiological changes to occur, the respiration has to be established, and that that inflow of oxygen or the atmospheric air to the fetal lung is what expands the lung. And once the lung is expanded, so the expansion of the lung, once the lung gets expanded, that convert it reduces the resistance in the lung and then turning the lung into a low pressure circulation. Making the systemic circulation more resistant than the pulmonary circulation, because it was as if something is collapsed before, collapsing on the vessels that are there, so making it difficult for blood to pass through those things, and then making the right ventricle pump against the very high pressure of the pulmonary bed. So with that, it's easy for blood to just move from the high pressure to the aorta. But once the fetus take a breath at birth, the lung expand and the blood vessels that were collapsed before, the expand, and the pressure that the right ventricle is pumping against before reduces. And instead of the blood diverting to the ductus arteriosus, most of them will now go into the lung for oxygenation, because the lung has started participating in in fact, has taken over the respiratory function at that stage. And this function, this has to start as early as possible. So in a very small number of cases, the ductus arteriosus remain patent, and then is referred to as patent ductus arteriosus. The increase in flow of blood to the lung reduces the pressure in the right side of the heart and increases the tension in the left side, because once the blood flows to the lung, you know that it's going to come back to the left side of the body through the pulmonary vein. So it increases the tension on the left side. The volume that is coming to the left side increases. And then that, because of the pressure building up on the left, it closes the valve-like foramen ovale. And if this does not occur, the mixture of the right atrial blood with the left atrial blood will make the oxygenated blood in the left atrium, the oxygen content of the left atrial blood to decrease. So it's important for the foramen ovale to close at least functionally early in life. So the part of the umbilical vein lying under the abdominal wall becomes thrombosed and occluded soon after the cord is tied and forms a fibrous cord. This fibrous cord is called the ligamentum teres of the liver. There's ligamentum teres, then the one below the liver, below from the umbilical cord to the liver, and then the one that connects the umbilical vein to the IVC, which is the ductus venosus, will now become the ligamentum venosus. So the hypogastric arteries atrophy and form a ligament between the bladder and the umbilicus. So it forms the ligament between the liver, the bladder and the umbilicus. But the one between the iliac artery and the umbilicus becomes the superior vesical artery. That forms the superior vesical artery. Then the ligament that this one forms, the ligament between the bladder and the umbilicus is called the medial umbilical ligament. Medial, not median, not N, is L. The median umbilical ligament is also there. That connects the bladder to the umbilicus and is the remnant of the urachus. So other factors that influence the circulation include the increased atmospheric pressure, which increases the systemic vascular resistance, causing lung to inflate with oxygen. So, and then the lung becomes the low pressure circulation. Let me use another diagram to explain this. Okay, so this, I don't know if you can see this clearly. So this is what I was trying to explain. This is the superior vesical artery. That is the previously the hypogastric artery and the umbilical artery. So the proximal part of the umbilical artery now becomes the superior vesical artery, while the distal part of it beyond the bladder becomes the medial umbilical ligament. And the median umbilical ligament is the remnant of the urachus, that is joining the bladder to the umbilicus. Then this is the previous umbilical vein, which form the ligamentum teres, and then the previous ductus venosus become the ligamentum venosus. Then the arteriosus become the ligamentum arteriosus. Hope this is clear. So this is just the to highlight few points of the between the fetal and the infant or neonatal circulation. So it's a low pressure system. The fetal system is a low pressure system compared to the lung at this point. So the right to left shunting occur. The lung is, because the lung is not functional and there's increased pulmonary resistance. So anything that you pump to the lung at this point will be diverted to the system, because the system is a low pressure system compared to the lung at this point. Then, but during the fetal circulation, during the infant period or the neonatal period or transition, it becomes a high pressure system. Because the lung has expanded and the lung becomes the low pressure system. The lung is now functional, and the diversion has to stop. So thank you very much for your, and I apologize once again for the first.
Thank you very much, Dr. Somalia, for the very lucid presentation. Please, chiefs on the platform, the floor is open. Hello, can you hear me, sir? Please, the floor is open for our contribution, sirs and Mars. Should I call on specific people as Chief Opopi would do? Okay. Dr. Alagbe, please your comment and contribution. Thank you.
Okay. Good evening, everyone. Thank you for the presentation, Dr. Amodu. I think he said everything I had in mind. Thank you.
Thank you, ma. Dr. Ruki, Dr. Uzoke. Dr. Sorikonte, please in that order.
Thank you very much for the presentation. It was very, concise and took up all the details. My network also fluctuated a bit. So I don't know if this was already mentioned. Some of the clinical applications of the ductus arteriosus is, when there's an obstructive lesion and there might be need to keep it open in neonates. So I don't know if you could just help us talk about that. There might be need to keep it open in neonates to aid their survival, because once it's allowed to close within those few number of hours after birth, then that neonate might die. So there are factors I know that keep it open and factors that can be used to artificially keep it open or close it. Thank you.
Do you want to respond to that, sir?
Hello?
Hello, sir. Do you want to respond to that? Factors that will come into play that we need to keep the PD open, the medications.
Hello? Can you hear me?
Yes, sir.
Yeah. There are some conditions in extrauterine life that are not compatible with extrauterine life, except if there's a right to left shunt or a connection, that is an extracardiac shunt, like transposition of the great vessels and some other ones. So if there's a need to keep the ductus arteriosus open, the prostaglandin generally have been shown to be, and its analog generally has been shown to be useful in maintaining the patency. And then if there is a need to artificially use drug to close it, indomethacin has been shown to also be useful in that regard. Those are the few points I can make about that. I don't know if there's something to that. Thank you.
Thank you very much, sir. Chief Examiner, sir. Dr. Oyebozi.
I think eventually, yes, we captured almost everything. I wouldn't have much to contribute again.
Thank you very much, sir. So says Dr. Conte too. Dr. Rimolade, any comments?
No comments. Thank you.
Okay, thank you very much. Chief Hamodu, you've done
Yes,
excellent, and we appreciate this, sir.
thank you very much, ma'am. Thank you, everybody, for the word of encouragement.
I would like to call on Dr. E.G., Dr. Kopi, Dr. Kweki, and very sure that they will have additional stuffs that will be useful that they need to add to this. Dr. Ijisa.
Okay, yeah, good evening, everyone. I just
Yes.
have a few comments. First, that it's a great presentation. Uh, um, However, I would have preferred that he was discussing the fetal circulation with the diagrams, first of all. He had, read some slides before he came to diagrams. During the exams, you don't have so much time to start reading through slides. This kind of presentation, just, place the slide and then discuss it so that everyone can follow. That's one. And then you discuss fetal circulation without discussing the role of prostaglandins, which I think is very, very important. The last speaker or previous speaker tried to raise it up from another angle. That will be, maybe I'll just say a little about it. We know that the prostaglandins, they play very important physiological roles in the fetus. One being the maintenance of patency of the ductus arteriosus. Now, this it does alongside, I think, nitric oxide. The thing is that the ductus arteriosus is actually programmed to close postnatally. That is why most times when babies are born, hours later, functionally, the ductus closes, and then anatomically, I think it takes, I can't remember, it is 2 or 3 weeks, but functionally a few hours, and then anatomically, I think after, I'll check it up. Now, clinically, the importance of this is that in preterm infants, they will usually, most of them or some of them will usually come down with a patent ductus arteriosus. Like I said, this DA is usually programmed to postnatally with decreasing, levels of prostaglandins. But in preterm, this has already been programmed, and then the baby is born prematurely. That closure does not happen, and then they come down with PDA. So PDA and preterm is a risk factor for development of PDA. The other thing is, I think he really didn't explain the reason why, of course, the reason why blood does not go into the left side of the heart. We know there's no functional lung here in the fetus, but there are, let me say, molecular reasons why this does not happen. There's the pulmonary vascular resistance is way, way higher than what you find in the systemic circulation of the fetus. Now, we all know that when we have hypoxia, or if there are areas in the lungs where there's reduced aeration, what usually happens? Naturally, blood will look for areas where there's something we call reactive vasoconstriction, to push blood away from areas that are less aerated to areas where you have, more air in the alveolus. So in this case now, this fetus has no air coming in because, or the lungs of the fetus has no air coming in because the fetus is inside the womb. It has no way of getting its own oxygen. So it means that all the alveoli, they usually have no oxygen. Therefore, the vessels in the lungs are all constricted. So the pulmonary resistance is way, way high. And because of those shunts, we know that our blood will find areas of least resistance. And then you find this blood flowing across the foramen foramen now, into, the other side of the heart, rather than going into the pulmonary circulation. And then the little blood that finds its way into the pulmonary circulation also will eventually find its way into the aorta to be pushed to the tissues of the fetus. So I think that's just basically what I would want to add.
Thank you very much, Chief, sir. We are very appreciative of the additional comment. Chief Okpope, sir. Chief Okpope, Chief Kweke.
I'm here, but I'm currently very busy with something. I won't be able to comment so much, but the part ahead sound fantastic. Just to make sure that you know the clinical correlates. So that's the most important part of this fetal circulation. Even if they're bringing this as an anatomy station, you ask it to relate to the clinical correlate. So I expect us to just put that together. Thank you. I won't be able to say much. I'm quite busy with something.
Thank you very much, sir.
All right.
Yes, sir. Dr. Opope. I guess Dr. Opope is also busy. Dr. Opope. Okay. Chief Amodu, please kindly help us add the part of the prostaglandin to the slides before dropping it, then the additional clinical correlates, sir. Thank you very much, sir. Dr. Ozuki, over to you, sir.
No, carry on.